Thank you very much for joining us today on the program Healthy Living. I'm Adesu Wausa. Today on the program, we want to look at something that can create a lot of problems for women, particularly the pregnant ones, if you do not go to the hospital. Sometimes things happen and then you choose to listen to other persons just because they happen to Miss A or Mrs. A, and you know, they found a way around it. Does not mean yours is going to end that way. We want to look at bleeding during pregnancy, particularly early pregnancy. What are the causes? What are the signs and symptoms? What are the things you do to make this happen? What are the things you ought not to do? What are those things you should not do at all to prevent bleeding? Or is it a natural cause? Is it something that happens within the body of the woman? You know, these are many more we're going to be looking at on the program today. And we also want to see if bleeding during early pregnancy is the same thing as spotting. Some women will say, oh, they're spotting. Others will say it's actual bleeding. So spotting, bleeding, is it the same? Or are there differences? All right, Dr. Steve Ogboma, consultant and gynecologist, will be here in a moment to talk this with us. So we'll take a very short break, and when we come back, we'll be discussing with Dr. Steve Ogboma. Stay tuned.
To search, the thrill, the glam is all about Miss ITV Hot Leg Beauty Pageant and ITV Radio Fashion on the Runway 2019. Are you pretty, intelligent, good looking, and you've got what it takes to be the next beauty queen? Then go get your form now for free to contest for Miss ITV Hot Leg Beauty Pageant 2019. Wow, it's getting better, bigger. 15 years since standing and it's rolling. You can get your form now for the following places: Independent Television and Radio, Glass as Effort Road, Benin City, or Beauty Event, Multimedia and Modeling Agency, number 10 Hyphen Street, off the Kiwan Road, Benin City, and be a local winner of our car and other fantastic prizes. ITV Radio Fashion on the Runway 2019. Are you a fashion designer? Do you run a fashion school or a fashion home? Then go take your phone now for 5,000 naira to contest for ITV Radio Fashion on the Runway 2019.
Chairman of the occasion, Barrister Case Domorabo, constitutional and human rights lawyer.
Audition day, 8th of November 2019. Time 10 a.m. Venue, Exquisite Home 2, Ihamaru GRA, Benin City. Grand finale, 1st of December 2019. Time, red carpet, 3 p.m. Main event, 4 p.m. Venue at Lower Royal Holland Suite, Sample Road, Benin City.
This event is supported by Oviomo Foundation, helping to build a better society through numerous platforms.
Vive La Vive Boutique, sales of female and children clothing, shoes, bags and other accessories. 11A, West Uba Road, After Water Resources, and located at Market Square, Sapler Road, Benin City.
Fortune Skincare, 61 Adesua Grammar School Road, off Uba by Water Resources. The Bliss Hotel and Suites, 163 Punja Home Motel Road, Benin City. And the Model Cooking Gas, 247 MM Way, Benin City. Wesley Premium Table Water, number 2, Wesley Street, Oka Community, off Benin Sapler Road, Benin City. Honorable Michael Izomo, CEO, St. Izomo Farm Organization.
Ogbe Motors Nigeria Limited, 202 Sapler Road, Benin City. Global Foods and Cinemas, 59 Urubi Street, Benin City. Samotaka Generators and Electronics, number 66 Wire Road, Benin City.
For sponsorship and participation, call this number 080-5656-3675 or 080-5673-3170. Miss ITV Hot Leg Beauty Pageant. Discover the beauty in you. ITV Radio Fashion on the Runway. Needle and thread. Creativity at its best.
Thank you very much for joining us on the program Healthy Living. What is the kidney?
The kidney is an excretory organ in the body, which is for metabolism.
Tuberculosis affects many organs in the body, but the common ones it usually affects is the lungs.
Epilepsy is a neurological problem.
Okay.
It is an injury in the brain which causes someone to begin to convulse, to go into fits.
It is curable, but the cure is a long-term thing.
If you eat well and avoid those risk factors that will make your immunity to be down, then the risk of contracting tuberculosis will be reduced.
If you're healthy, then you're wealthy. All right, thank you very much for joining us again on the program Healthy Living. Like I said before, we're going to be looking at bleeding during early pregnancy. Even in pregnancy that is quite advanced, okay? Bleeding can happen at any time. I'm sure the doctor will let us know why and what. Join me as I make welcome Dr. Steve Ogboma is the Medical Director, Gable End Specialist Hospital here in Benin City. And he's, of course, a gynecologist, a consultant gynecologist. Yes, Dr. Steve, it's been a while.
Thank you very much. I'm
So
well
how are
done
you
with
today?
you. I'm fine.
Okay.
You're
So
most
happy to
welcome.
have you today
Thank
on
you.
the program.
Thank you.
Now, we're looking at pregnancy and bleeding.
Yeah.
Can you tell us why a woman should bleed during pregnancy, particularly early pregnancy?
Yeah, women bleed in early pregnancy, but you know it causes a lot of anxiety when women bleed in early pregnancy, and the anxiety is
As early
associated.
as like a month, 2, 3, 4.
They can bleed just at the very beginning. The earliest bleeding a woman sees in pregnancy is what we call implantation bleeding.
Implantation bleeding.
Yes. So when the human oocyte, you know, forms a zygote, it moves through the tube back into the uterine cavity. It wants to implant and embed. As it sinks into the bed of the lining of the womb, we call the endometrium, there's a little bit of bleeding. Okay. And in most cases, spotting. About 7 days after the woman would have missed her period. So it's nothing to worry about. It's a natural phenomenon that occurs at the earliest part of pregnancy. So that is normal, and women should not worry about it. Then there are other subsequent bleeding. Bleeding can come from the pregnancy itself. Bleeding can come from the placenta site. Bleeding can come from the lower genital tract, including the neck of the womb, we call the cervix. So all these, you know, are associated with bleeding in early pregnancy. If you are worried, apart from the bleeding that occurs, that comes in spots, you know, just a little stain on the knickers. Apart from that, all subsequent bleeding should make you see your gynecologist so that they can ascertain the viability of the pregnancy.
All right, some women have actually experienced bleeding during early pregnancy and eventually they lose the pregnancy. Because you just said that it does not really matter if a woman bleeds in early pregnancy. So what would make a woman bleed in early pregnancy and lose that pregnancy?
Okay, so there are other complications that can occur, you know, in early pregnancy. God in His infinite mercy has produced eggs. Some of them are normal in terms of the number of chromosomes, and some of them are abnormal in terms of having fewer or more chromosomes than the normal complement. When the chromosomes are abnormal, the body rejects it. We call it natural selection. So within 6 weeks, 8 weeks, you can have a miscarriage. You can have bleeding that can result in a miscarriage. Initially, you have what we call a threatened miscarriage. When there's a threatened miscarriage, you just see some blood. There's not much the doctor can really do. We'll prescribe bed rest, but there's no scientific proof that bed rest prevents subsequent miscarriage. A baby that will miscarry will miscarry. But in 20% of cases, women that carry this pregnancy, that bleed in early pregnancy, carry the pregnancy to term. But there are other complications associated with pregnancy that can occur later on in pregnancy. At 6 weeks, 8 weeks, you can bleed. Not because the implantation period has you passed it. You can bleed not as a result of having a threatened miscarriage. You can bleed because the pregnancy is not in the correct location. Okay. The correct location is within the womb, but sometimes the pregnancy, you know, deviates from the normal route, ends up in the fallopian tube. We call it ectopic pregnancy. It can end up in the ovary. It can end up in the pouch of Douglas. It can be somewhere that we doctors cannot locate it. We call it pregnancy of unknown location. So all
so
this can happen.
what could be the reason for that pregnancy of unknown location? That's strange.
Yeah, it's strange.
And doctors cannot locate where that pregnancy
is. You do a scan, you do the blood test. The blood test tells you that there's pregnancy.
Okay.
You do what we call a serial beta HCG check, which is the hormone associated with pregnancy. You see a rise, which is associated with an ongoing pregnancy. But you do a scan, you cannot find anything in the womb. You cannot find anything in the uterus, you cannot find anything in the fallopian tube or in the ovaries or anywhere in the pelvis. But there's evidence of pregnancy. So you call it pregnancy of unknown location. The management is very specific, and if you meet your gynecologist, you won't need to do surgery because it can be managed, scientifically, and patient will be well. So
and such a pregnancy, can it be bettered?
No, because it's of any pregnancy that is not within the womb, the chances of ending up as a viable pregnancy is very much reduced. Wow. Yes, but we do know that pregnancy can occur in the peritoneal cavity and be carried to term after it is detected. But in the earlier part, when a woman comes with pain in the lower abdomen, bleeding from the lower vagina, and scan shows nothing. Before 6 weeks, 5 weeks to 6 weeks, if you don't have a good scan, you may not be able to locate a pregnancy within the womb. But if you are using the proper scan, at 6 weeks, you should locate something.
What do you mean by proper scan?
Not all the scans have the same power to determine the location and the viability of pregnancy. Some scans are not as strong, they're weaker.
Which is a proper scan now, so that the woman would just go straight for that proper scan instead of wasting money with the ones that are not proper now, in quotes?
Yeah, not all
are
the
there
scans.
Specific machines?
There are specific machines, but even the machines, they are variable. They are graded. Some just able to pick things, some are able to go beyond and see a lot of things. So not all scans are the same.
All right, let's talk about bleeding as a result of ectopic pregnancy.
Yeah, bleeding from ectopic.
Explain to us again what ectopic pregnancy is and why a woman will bleed and what will happen afterwards. Just give us a little bit of
ectopic pregnancy is associated with previous problems in the pelvis, like pelvic inflammatory disease, like sexually transmittable infection, like previous surgery, like congenital malformation of the lower genital tract. All this can predispose to ectopic pregnancy. Anything that changes the contour, the normal anatomy of the pelvis, can predispose to ectopic pregnancy. So in a normal pregnancy, conception takes place in the tube. Okay. The sperm comes from below, the air comes from above, and they meet in the ampullary region of the tube. They fertilize, and that fertilized, we cannot call it moves from one stage, becomes a zygote, subsequently it becomes a blastocyst. It moves back into the uterine cavity and gets implanted. Once it gets implanted, that's when the woman loses a little bit of blood. They call, implantation bleeding, just spotted. But in ectopic, it does not go the right way. Maybe the tube is kinked because of previous infection or adhesion or pelvic inflammatory disease of any origin. It's not able to get to its proper location. Then it embeds there and starts growing. When it grows, because it's not in the right place, it stretches the nerve endings on the tubes, for example, and the woman gets pain and she bleeds because there's still a link between the tube and the uterus. So, and the bleeding is seen per vagina. So this happens. That's in the typical ectopic. Sometimes.
So when that happens, what should the woman do?
The woman, once she has pain, pelvic pain, positive pregnancy test, and bleeding, you should go straight and see the doctor. Then they will confirm the location of the pregnancy on an ultrasound scan. And once that is done, then it's not ruptured, that's unruptured ectopic pregnancy, then the gynecologist can safely remove it through a pinhole and take it out. But in certain situations, people are always very slow, unfortunately. Yes. They don't go to the doctor, they just want to manage. Then the growth becomes too big, it bursts, you know. We use the word rupture. The ectopic pregnancy ruptures, and there's violent bleed. So the woman can lose a liter of blood into the peritoneum, into the inside of the womb within a very short time. And this can be fatal for the woman. So she needs to go to the doctor immediately, and she doesn't need to wait around as in an emergency. She needs to be taken straight from when the problem is diagnosed straight, you know, to the theater, so that it can stop the bleeding. Because once the petrol in the car is exhausted, the car will stop. That's what blood is to the human body. Once the bleeding is too excessive, and you know, the woman stops.
All right, when you were talking, you talked about sporting, you talked about bleeding. Sporting and bleeding, are they the same?
No, not at all. Okay. You know, if it's sporting, just little sports, that's minimum blood loss. So we can call that spotting. It's a stain on the nickel, a stain on the pad. So that's spotting. But when they bleed, the bleeding can be mild, moderate, or very severe, you know, which is unfortunate. So all these can lead to the woman, you know, number one, becoming exsanguinated. That is all of her blood, you know, is just exhausted, and she's unable to carry on, and she expires, which is unfortunate.
Okay, the number is 052-290-573. 052-290-573. That's the number to use the colors. It's our usual number, okay? So you can call Dr. Steve Ogboma, ask him every question you want to ask him, all right? If you're having any problem with pregnancy, particularly early pregnancy, and you're having serious problems, I think you should call the doctor. And if you don't want to call the doctor, I think you should see your gynecologist. You just have to, okay? Those days are gone that you say, oh, it happened to my sister, so I may not just have problems. You may have serious problems, okay? All right, doctor, you just talked to us about spotting and bleeding. Now let's look at bleeding in pregnancy that is quite advanced.
Okay. You can have blood loss later on in pregnancy. So blood loss after 14 weeks. It can come from the placenta side. The placenta embeds, and sometimes there's a little blood loss from the placenta, causing a separation of that part of the placenta we call retroplacental hematoma. That's the collection of blood. In certain situations, it can increase the blood loss and separate the placenta from the source of, you know, the nutrients and oxygen, and that pregnancy can be lost. But in certain situations, you know, just manage conservatively without having to do anything. Bed rest is helpful in this case, so that the blood loss is minimized, it stops, and the pregnancy, you know, continues. That's one type. Okay. Another type is that the placenta can separate from the edge, just marginal bleed, and the woman sees blood loss. She goes to see the doctor. They do what we call a vaginal examination using the speculum, look at the neck of the womb, and exclude other causes of bleeding. Once that is done, then they can do a scan and confirm that the pregnancy is viable and the placenta is appropriately located. They can manage conservatively. But in certain situations, the bleeding is so torrential because the placenta completely separates from the womb, and that is an accident. And sometimes some women can trip and fall. Sometimes a blow to the abdomen, a pregnant uterus can cause it. Then the placenta can accidentally separate. Sometimes nothing happens. It just occurs with a violent uterine contraction, placenta separates, the woman starts bleeding. Sometimes the bleeding is concealed. She's losing so much. She's concealed. She's become paper white. She becomes listless. The pulse are thready. That's why we're looking at the pulse of 150 or 140, something like that. The blood pressure plummets, and we need to, the doctors or the attending physician or gynecologist or surgeon needs to move fast, to give the woman fluid, blood, and remove the source of bleeding and contract the uterus, so that the bleeding stops. That's an abruption. Okay. But there are times when we have another type of bleeding, when the placenta covers the root, it's on top of the os, in the lower segment. Sometimes it covers it completely. We call it a major, placenta previa, or it covers it minimally. We call it a partial placenta previa. That's just, we can type it into 1, 2, 3, 4. Let me not go into all the clarification. Just make it simple, either complete or major or partial. And in this case, the road is covered. Yeah. But as the pregnancy advances, it stretches the lower segment. Then the womb separates from the placenta that is located in the lower segment and covering the os, and the woman starts to bleed. We call that as, it's a placenta previa. It's a bleeding from a placenta previa. It can be minimum and bed rest. Usually it gives warning sign. Initially, it's just a little bit amount of blood. Then subsequently, there's a moderate amount of blood. Then subsequently, there's a violent, serious, severe blood loss that can exsanguinate the woman and can make her lose the baby or can make her lose her life. In that situation, it's a cause of maternal morbidity and mortality. Then you will determine the viability of, there's no time to determine the viability of the pregnancy. What you are after is not the baby now, is to keep the mother alive. So if she's bleeding so heavily, you quickly do a cesarean section. And depending on the age, you can do a lower segment. If it's if it's above 26, you treat normally. Okay. If it's below, then you do what we call a classical and remove the placenta and clean the lower segment and suture back, give you one fluid. Once the source of bleeding is stopped, then the woman recovers. You give her a few units of blood, 2, 3, as the case may be. Yes. Yes, in subsequent pregnancy, if the pregnancy gets located in the appropriate place, either anterior or posterior or right lateral or left lateral, as the case may be, pregnancy can be carried to term.
Well, what if the placenta is severed from the baby, sort of?
Well, that is a cause of intrauterine death. We call it fetal death in utero, FDIU. That's what happens. When the baby loses supply of oxygen, supply of nutrient, the baby cannot cope for too long.
Can you tell us why that would happen?
Why that would happen?
Yes.
Well, it's one, I've just mentioned to you that this placenta is located in an abnormal place. Yes. The womb contracts. When the womb contracts and it retracts. So as it's retracting, it's separating the placenta. It's a normal physiology, in which case it should not, the placenta shouldn't be there, but the placenta is in inappropriate location. Because of that, it separates completely from the uterine lining, which is the life wire for the baby. So the baby loses source of oxygen in addition to nutrient, and the baby expires. But if it happens and they come to the hospital on time, and if you have an emergency team, they will salvage the situation. On very rare occasion, we lose babies.
On the age now.
Yes. If, after 26 weeks, we are more likely to salvage the situation, in other climes. But here, 28 weeks, I know they were doing 28 weeks very well in hospitals. They could salvage 28 weeks very well. 26 weeks, they can struggle, But sometimes we judge by weight, like the Americans. You know, 500 grams baby is likely to survive. But after that, less than that, you know, the chances are very low. But the thing is that when that kind of baby survives, the baby has a lot of problems. Minimal brain damage, the heart and the lungs, we call it hypoplastic lungs. The lungs does not expand so that it cannot breathe. The baby may not be able to walk from there to there. The developmental milestones are all retarded because the brain is not working well and all other human physiology from all the other organs are affected. And this can affect the final outcome. In certain situations, when the pediatrician will hold a meeting, you know, what we call multidisciplinary team meeting. You have the obstetrician, you have the, you know, the neonatologist, that's the baby doctor, you have a physiotherapist, you have the midwife. We all sit down, discuss. The parents or relative or the solicitor representing the parents will be at the conference. You now take a decision. Do we switch off, you know, resuscitation because of the likely complication that will occur subsequently, or do we leave it? Depending on the religious bias of the parents, they will decide one way or the other. But usually, some of the babies expire on their own, but at other times, they grow, but they usually end up with a lot of problems.
Is it not better to let the baby expire than this?
Yeah, but you can't take the decision. The decision has to be made by the parents. And in particular, the mother. The mother has 90% of what to say.
Okay, in relationship with this, I've often heard that when a woman bleeds during early pregnancy or even later in pregnancy, the baby may not come out well. The baby may come up with a lot of complications like the one you just explained, or even more. How true is this?
Well, it depends on what the pathology, what the problem is. You can have a threatened miscarriage and the woman bleed at 12 weeks, for example. She bleeds and you monitor her conservatively because there's nothing to stitch or to hold to make the bleeding stop. But there are some drugs that will make the blood to clot. But one thing is that sometimes the clotting may not be limited to, you know, the bleeding side. It can go beyond the level of the womb and can form a clot in the brain or in the heart that can kill the woman. So these are drugs you have to use very, very sensibly to arrest hemorrhage in this woman. But you can't use them, you know.
So at what stage should the woman see a gynae? Because some women, when they are pregnant, some will wait till 6-7 months before they say, okay, time to go to the hospital. This is when I want to go for antenatal. You know, I'm a strong woman. I come from a lineage of strong women. We don't really have to go to hospital and stuff. So they wait some don't even, the first time they will go to the hospital is at the point of birth.
Yeah, that's wrong.
And what is the appropriate time a woman...
When you miss your period.
Yes, when you miss your period, and then care.
Yeah, immediately you miss your period, you should go and see your doctor to confirm that you're pregnant and to confirm the location of that pregnancy, if it's in the appropriate place. Once you miss your period, you do that. Even, you know, in other places, they do what we call pre-pregnancy, you know, clinic visit. Before you get pregnant at all, you go and see your doctor.
Not in this part of the world.
You go and see your doctor, now you're planning your pregnancy. Because pregnancy is not just to have a baby. You have to plan financially. You have to plan in terms of your housing. Because if you're living in a one-room apartment, by the time you have a baby, you need a two-room apartment. You need space for the baby. All right. Financially, morally, economically, all this come into it in the planning, you know, to have a baby. So there is a place for pre-pregnancy clinic. Then immediately you miss your period, you should go and see your midwife. Then you do your first scan, we call a viability scan. Then after that, you do what we call a DT scan. Then after that, you now do an anatomy scan. The anatomy scan checks the brain, you know, of the baby, the eyes, the sex, the chest, and look at the heart and the lungs and the kidneys, the bladder, and the length of the legs. Sometimes you can have babies with shortened bones, achondroplastic babies. You check all these things. Okay. Then you can tell the woman, okay, this is a normal, healthy-looking baby. All that is left for the baby to just grow and attain maturity. Yeah.
All right, the number is 052-290-573. Dr. Steve Ogboma is our guest today. He's a consultant gynecologist and the CMD of Gable End Specialist Hospital in Benin City. 052-290-573. Give us a call, ask all the questions that you need to ask, okay? It's got to do with you, not me. So ask the question and stop believing in the fact that because it didn't happen to your sister, it cannot happen to you, or because it did not happen to your mother, it cannot happen to you. Doctor, while we're waiting for calls, we're seeing a situation where a woman will lose fallopian tube because of ectopic pregnancy, and maybe she tries again, she will lose the other. What's the hope for this woman? Or what are the things she should do? Or are there things she should do to check all of this so that it doesn't happen again? Because I know of somebody who lost one and then lost the other.
Yes. Well, if you have an ectopic pregnancy, in the past they used to conserve the tube, but science has shown that when you conserve the tube, the likelihood of a repeat ectopic is quite high. So we now, we now take off the tubes. When there's an ectopic, take it with the tube. What can a woman do? A woman can be seen at the end of that initial management. Can have a scan, release the adhesions, look at the pelvis, release the ovaries from adhesions, through the laparoscope, through the pinhole, and clear all the pelvis of adhesions. Then if she has residual infection or subclinical infection, then she should be treated. Okay. But in the other case, she may end up with another ectopic on maybe she had it on the right side, then next she gets it on the left side. If it happens on the left side, then she has lost both tubes. But the ovaries are still present, in which case she can still have a pregnancy. Science has is so advanced. There's a place for, assisted reproduction.
So let's pick this caller. Hello, caller. Good afternoon. Hello. Please, when you're calling, you will do us a favor by reducing the audio level on your telephone set or your television set. Hello, caller.
Hello, good afternoon.
Good afternoon. Please tell us your name and ask your question.
My name is Precious Emmanuel.
All right, Precious. What's your question?
Good afternoon, ma. Good afternoon, sir.
You're welcome.
I want to ask about a woman that is married almost 4 years, but she has not any issues. What can cause that problem?
Okay, married for 4 years.
Because she has undergone some serious tests. They are telling her that she has an infection, and she's treating the infection. Nothing has happened.
Well, there are a lot of factors that can make a woman, not to get a pregnancy, not to achieve a pregnancy. One, the factor of age. There is an inverse relationship between age and pregnancy. But I assume that this person is a young person, so age may not be a factor. But the major problem we have in this part of the world is disease of the pelvis, disease in the fallopian tubes. Those tubes may be blocked. So you need to check either by ultrasound scan or by HSG. It's a type of scan when we use fluid and turbulence to check if the tubes are open. Or if we do it the age-old method of doing the HCG, where they put a dye and take pictures, and on the basis of the pictures and the flow of the dye into the abdomen, you can say, oh, the tubes are open, or fully open, or partially open, or the right side is open, the left side is blocked, or the reverse. All right? So that woman needs to be investigated You want to check, is she releasing eggs every month? Or is she having abnormal ovaries, what we call polycystic ovary disease? You know, when these are the problem, she won't release egg like her sister will do, or like her mom did when, you know, she was making babies. There are a lot of factors that can be responsible. Sometimes there might be a congenital malformation of the womb, of the neck of the womb, you know, or of the implantation of the tube to the womb, and that can interfere with her ability to achieve a pregnancy. It may just be a genetic problem, or it may be a chromosomal abnormality that she's carrying the wrong chromosomes. All these need to be tested. Once you have done all these tests and yet you cannot see a problem, you cannot detect a problem, then you can make a diagnosis of infertility of unknown cause. Then that kind of patient can be referred for assisted reproduction, in which case, if she's producing eggs, then we can harvest the egg, you know, harvest the spermatozoa from the spouse or partner, as the case may be, and put them together outside and put them in the tube. Or if she has no tube, then somebody else can help, you know, we call surrogate. So there are a lot of things she can do to achieve a pregnancy. The thing is not to give up, and the thing is not to wait. If you are young, the earlier you do everything, the better. Once you start hitting 30-something, on the wrong side of 35, then things become difficult, because all factors, you know, they reduce in terms of efficiency and efficacy in achieving a pregnancy.
All right, 052-290573 is the number. Hello, caller, good afternoon. Hello? Hello? Can you reduce the audio level on your television set, please? Hello? Just move away from where your TV is. I will not take this call. Hello?
Good afternoon.
Good afternoon.
My question is, why is it difficult for a woman that undergo CS to have difficulty getting pregnant again?
Why is it difficult for a woman who has gone through CS to have babies again?
Yeah.
That's news.
Well, generally, cesarean section is a straightforward operation. It should not interfere with subsequent pregnancy, because the operations are not done the old ways. They cut across rather than cutting up and down, and the things are restricted to the lower segment. But sometimes you can have what we call subclinical infection. There is infection, but it's not full-blown, that will hit the woman and make the woman to sleep, or make her to have a discharge, or to have pelvic pain. But there's a subclinical infection that can interfere with the endometrial lining, and that can prevent subsequent implantation. So that is a factor.
So when that happens, what should the woman do?
The woman will come, they will take samples and culture it and see the offending bacteria and treat with the appropriate antibiotics. We can have a look. Sometimes after cesarean section, when there has been an infection, the size of the womb, they become attached to each other. Or you have a book like a Bible or your dictionary, you pour water into it, they gum, and you forget to spread it out. They get attached, you know. So that space is obliterated. That the womb, the uterine cavity is obliterated, and nothing can go in. So in that case, from HSG, from hysteroscopy, you know, you can detect there's a problem, and you can deal with the problem straight away, and keep the womb apart with some technique, and give the woman some drug to make the lining of the womb to grow luxuriantly, and you remove whatever you kept there, and this woman can end up achieving a pregnancy. It's just to do the right thing.
Okay, though it's hard for women to go to hospitals, particularly the ones that have had babies before, maybe several years after, no babies are coming, and you begin to wonder, is it possible for this woman to suddenly become infertile after a child or two?
Yeah, women can, they can become subfertile. I won't say infertile, subfertile, but it might be as a result of a problem. So what the doctors need to do is to find out the cause and treat it. Usually, in most cases, when the cause is removed, the woman go on to have a pregnancy.
Okay, that's interesting. Let's look at miscarriages now. Do we have a call? Hello, caller. Hello, good afternoon. Hello, can you speak up?
Good afternoon, ma'am. Good afternoon, sir.
Good afternoon, madam. Tell us your name and ask your question, please. Can you tell us your name? Hello? Okay, we're not going to take that call because I did say that when you are calling, you will either reduce the audio level on your television set or you move away completely from where your TV is. It is impossible for you to hear yourself whilst we are talking here, okay? So just move away. All right, move away, make your call, ask your questions, then switch off your phone. The doctor will be able to answer you. Hello, caller, good afternoon. Hello, good afternoon.
Good afternoon, ma'am.
Yes, tell us your name, please.
My name is Joy.
All right, Joy.
So, it's something I want to tell you. So, what happened to me 2016 on the 11th December 2017?
Joy.
I did a pregnancy. Since then, I have not pregnant.
Okay, you know what you do? Reduce the audio level on your television set or move away and ask this question again.
Hello?
Hello, Joy. Okay, ask your question now.
Hello?
Hello?
I said 2016.
Okay.
On the 11th of December 2016.
Okay.
I had an ectopic pregnancy and I did the operation in UBC.
You did what?
I cannot even.
Did an operation.
Okay, yes.
Not even pass at all. Cannot even pass at all.
Okay. All right, doctor, were you able to catch
Well, it said she had an ectopic in 2016 and she had surgery in one of our hospitals. She's not been able to achieve a pregnancy. It's just what we have been discussing. She's lost one tube, so she's left with one tube. Okay. But you only need one eye to see. But two eyes are better, two tubes are better. So the thing is not to give up, to try and check.
What is she to do now?
What she needs to do, she should see someone. She should see a gynecologist, one, who will check if she's releasing eggs and check if the Ole tube is still open, is patent, and check if the partner's spermatozoa is viable, is live bullets, in which case, we check all these things. Once you check, then she might achieve a pregnancy. And we take her age into consideration. If you think the age is becoming too advanced, then you advise her to move on to do assisted reproduction instead of just trying and trying and trying. And she might lose from all ends.
Right, 0522905573. Hello, caller. Hello? Can you reduce the audio level on your TV set? Hello?
Hello?
Hello, good afternoon.
I'm Mrs. Okuma, sir.
Okay, how are you?
I want to ask, due to the program that is on in the television right now.
Yes.
Concerning the miscarriage and bleeding during early pregnancy.
Yes, go ahead and ask your question.
Okay. My question is that in my church, there are some people experiencing ectopic pregnancy. So it's not going and it's not doing, they're not, with the pregnancy is not seen in the scans. So I want to know what can we do. Hello?
Okay, so what is the question? What do you want to know?
Hello?
Hello, what is the question? What do you want to know?
People are pregnant. We can't see them on scan. What shall we do?
People are pregnant.
You cannot see them
And
on
you
scan.
cannot see the pregnancy on scan.
Yes, on scan.
Yes,
Wow.
that's a problem. You know, during the earlier part of this discussion, I mentioned pregnancy of unknown location. Okay, there are two ways of detecting whether a pregnancy is there or not. You can do a blood test for beta HCG, and it's normal. It shows there's evidence of a pregnancy. But when you do a scan, you know, you may not see anything. One, the quality of the ultrasound scan. Is he very effective? Is he able to detect the absence of the pregnancy? Two, what is the age of the pregnancy? If the age is less than 5 weeks, you may not be able to say anything. You just wait. You know, without doing anything, just wait, give it a couple of weeks, then you have a repeat ultrasound scan. You might see the scan that was negative becomes positive. Then you see an intrauterine pregnancy. But if there is no pain, there's no bleeding, you can wait, you know, and repeat the pregnancy test. If it shows that there is still increase of the hormone, it might tell you that there is a pregnancy there. But all the ultrasound scan might not be able to detect it. One, you may have lost the pregnancy, we call it a missed miscarriage, or it's a pregnancy that you cannot locate. But you have to use both methods, both blood tests and ultrasound scan, to determine what is going on. And you yourself may observe that that pregnancy feeling you were having 2 or 3 weeks ago are no longer there, in which case you've lost the pregnancy. Although you did not bleed, and we call that a missed pregnancy, a missed miscarriage.
All right, we'll take this one more call, and then we'll call it a day. Hello, caller. Good afternoon. Hello? Can you reduce the audio level on your television set, please? Hello, caller.
Hello.
Yeah, good afternoon. Can you speak up a bit?
Yes.
Okay, tell us your name and ask your question.
Some women, I'm occupied.
Some women are what?
I'm Joshua. I'm calling from one.
Okay.
There are some women, after delivery, when they take place, they take problems here.
The line is breaking. I can hardly hear you, Joshua.
They have problem in hearing. Some women after delivery.
Yes?
Okay.
That is partially death or totally death. What can be done to prevent such? Or revive their hearing?
They become deaf or dead?
They become deaf.
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 Yes.
Okay. All right. What happens in such pregnancy is blood loss.
Blood loss.
Yeah. If the blood loss is so severe, then it can affect some of the very sensitive organs at the level of the brain, because the brain controls your hearing, your sight, and all that. Sometimes they may have what we call preeclampsia that can affect the eyes. So in that situation, they need a close monitoring and for a review, if it's eye by an ophthalmologist, and if it's ear problem, to assess what has happened. In which case, in addition, for determining, having a look at all these organs, they will do some hormones of the pituitary gland to find out if there is hemorrhage into or lack of blood in these organs, very sensitive organs. Okay. We call aseptic necrosis. The organs, they will undergo death, not as a result of infection, okay, but as a result of inadequate blood supply, because the woman was nearly exsanguinated at delivery, at childbirth.
Okay.
So, which is unfortunate.
All right. Time is spent and we've got to go. You want to do a follow-up on this topic, you can give us a call on 070-550-71439. 070-550-71439. That's the number to call us with to do a follow-up on this topic we discussed today. And this is all we're going to do today. Thank you very much, Doctor.
Thank you. Thank you very much.
On our show.
Yeah,
we're going to see you again on Monday. Until then, call, make all your inquiries, and above all, learn to visit the hospital if there is any problem at all. Don't wait until that problem overcomes you. We'll see you again. Bye-bye.
Thank you. Thank you very much.